Good morning, everyone. Welcome to this morning's webinar. It's my pleasure to introduce our speaker for today, Ms. Jeanette Raad. Ms. Raad works at Red Cross Children's Hospital, where she runs and delivers the urodynamic service. She's highly experienced in urodynamics and is one of the few people who offer this service in the country, making her expertise particularly valuable. Urodynamics is a cornerstone in the assessment of lower urinary tract dysfunction, yet it often feels intimidating or underutilized without a clear, structured approach. So today, Jeanette will be taking us through urodynamics. She'll be offering practical insights into a key component for everyday urological practice. Jeanette, you are free to share your slides and you can get started from your side. Thank you.
Sorry, good morning. Could you hear me?
I can hear you and we can see your slides. You can just make it full
Are you
screen.
okay? Fine. Okay, sorry, I've got a bit of a problem that there's no sound on the laptop, so I'm just doing a double on my phone. So I just hope you can hear me quite clearly.
We can
Um,
hear you clearly. Thank you.
okay, so now it's going to be a bit weird for me. I don't know you're not going to see me. It's fine. You all know what I look like. Sorry, it's a little bit awkward. Okay, sorry, good morning. And yeah, obviously welcome, but I'm sure you've been welcomed. So basically what I thought we could talk about today is I'm sure you all know everything about urodynamics. So I'll just go just a quick overview about the tests and what the results look like. But what I also thought if we could just look a little bit more about interpreting the results and why I kind of think this is quite important is I'm just finding a lot of times the no judgment. The doctors dealing with these kids come from a adult background, so it's looking with adult eyes at pediatric results. So I thought we could just look at a couple of studies and just hopefully um, to see things a little bit differently. So, sorry, I just want to see that. Okay. So basically, we talk about the function of the bladder. We know there's two storage and avoiding phase, and we know essentially what the detrusor is underactive and sphincter active during the storage phase, and during the voiding phase, it's the other way around. So obviously where dysfunction comes in when you have a combination of abnormalities in this, and they can be from not so serious to quite serious. So having detrusor, especially say if we're talking about during the voiding phase, being uh, underactive or overactive, and the sphincter being underactive or overactive. So there's quite a lot of combinations, and we can see these results a little bit further. So our standard diagnostic evaluation, very important is to have our history, examination, urine analysis, KUB. So I just wanted to highlight KUB. KUB is very important in that we do a pre and post MIC. I would kind of say it's almost essential in our children. I see a lot of studies where we are actually undercalling upper tract involvement because we are not actually filling the bladder. So it's just something to uh, consider, especially if there's upper tract involvement. Diaries are very important, bladder and stool. So these are very underused and very, very useful. So we'll talk about them a little bit more. Then we get our Euroflows, which is basically just like a screening test and with the residuals. And then we get to our invasive studies where we look at the cystometry, which is basically looking at our storage phase, pressure flow, storage and voiding. EMG is to look at the sphincter, and then the video UDS, which is like a gold standard for us. So if we're looking at the basics, how would we start? So essentially, if we had a case of an example of a 5-year-old male with primary daytime incontinence, and wet at night, no UTIs, and constipation on treatment already. So bladder stool is very, very important. Then we would actually need that before we even do the interview, and then we could do a Euroflow with ultrasound just to check. So just to quickly go over capacity. So in children, so from infants to 2 years, we use their weight and either 7 or 8 mils. In children older, so from 2 to 13, we use the formula, which is age times 30 plus 30. You'd also sometimes use age plus 30 plus 60. Plus 60, but in the bigger picture, it's only a 30 mil difference. So we can see our normal range is anything from 80 to 120%. Small bladder. So this is very important in our pediatrics. I think it's something that we're not always looking at. So a small bladder is something less than 65%. And this is actually very important because then we know we are putting the upper tracts in danger. So we always have to look at bladders that are smaller than 65% of expected bladder capacity, and then large is the 120. So here, if we look at the example of bladder diary for this child, so we say it's a 5-year-old, so we know expected bladder capacity is sitting at 180. So just looking at the diary, so we can get quite a lot of information. So basically asking for drinks, for voids, if the child is wet or dry. So bladder diaries should also be appropriate to the condition. So in this case, we know it's a child that's wet, so we also want to know if there's urgency and the reason for activity to see if there's distraction at the time. So we can see here, doing some recording. So a big alarm bell would be, you could see a child drinking 330 mils. So if I'm drinking 330 mils, my bladder is only 180. Am I going to be soaking wet? Yes, that's not, so we're not surprised there. So also just looking at their behavior. So he's drinking, so drinking and voiding is not in sync. So we also like to encourage children that are wet is we void and then drink. So that always that the bladder is empty before we drink. So it's a better way of monitoring. And we can also see what is maximum capacity for this child from a functional point of view, and we're seeing it looks like it's around about 110 mils. We also see obviously the wet soaking associated to this big drink, and then urgency. So obviously the child is having urgency, and we can see that wet is also associated with times that the child is now distracted. So the other very important one is the stool. So stool diaries are very important. So here the child is on treatment, and we can see, so essentially these diaries need to be run for 14 days. As consecutive days is very important to look at missed days. And then you can see we're looking at time of stooling, if the child's having multiple stools in one day, the type of stool is very important, the amount, and then obviously if there's any um, like straining, pain could be associated either with tummy ache or pain during defecating and soiling. So, and if there are any bowel accidents, so you can see this child had one accident even despite treatment, but basically quite well managed on his medication. So then we would do a Euroflow. So if we're looking at a Euroflow, so it's basically a flow rate over the amount of urine avoided. So this is our mils to flow, and this gives us a beautiful bell-shaped curve. So under the curve, we have the voided volume. We have how long it takes to void the flow time. We have the max, the Qmax. So that's quite important to see that the detrusor is contracting adequately. So according to these, we have different patterns. So we can just quickly look at the different types of patterns. We see a normal, which is bell-shaped. We also have a tower shape, so with quick upstroke. So here we can see a little bit of activity here. So normally with these tower shape ones is more from where you see maybe in boys where they're actually pinching the penis to control the flow. So, but we see a very quick upstraight, so actually would be our overactive. Then we have the ones with a very flat, consistent flow rate. So if you had to listen to it, it's like very so that's also a very um, good indication that it is a limited outflow. So if we can think of it as if you are pushing a tube of toothpaste, doesn't matter if you push hard or soft, it's always going to come out with that shape. So this is kind of telling us that there's a limited opening. Um, Obviously, it could also be a case where the tubes are starting to fail, but you wouldn't quite see such a consistent um, like tabletop, but it would something be then you would have to go and look at the pressures of the detrusor. In this case, we can actually see this looks like a nice bell shape, but it is there is these ups and downs, which is called a staccato pattern shape. So these are very significant if these contractions are, if we're taking the square of the max, and these have to be greater than that. So smaller ones are just more artifacts, but they're only significant if they are greater than the square root of the max. Um, and in this case, we see an interrupted flow. So, and this is telling us whether the trees is starting to fail. Sorry, I'm just feeling a bit weird. Can everybody hear me? Maybe I can just hear. Can everybody hear me?
Yeah, we can still hear you and if
Okay. Sorry. Yeah. Okay. Thank you. It's just I can't see anything, and I'm just hoping. Okay. Thank you. So I just wanted to also just for us just to look quickly at a normal bell shape. I often see that sometimes a bell shape is called a tower shape, um, overactive, and it's just because maybe when the studies recorded that there would be a long delay before the study stops, so giving you a very looking on the diagram like an overactive bladder. But key to this is if we're looking at the average flow and we look at the max, and we can see that they're around about 50% of each other. So that's a good indication that that's not a tower, but actually a normal bell shape. Also, the time to max, anything greater than 3. So these are all helpful figures. We also see there's a voided volume, so we can also compare that to the expected bladder capacity of the child, and we have the residual to see if the child empties bladder or not. So these are all very helpful data to look at. And in this case, with this child, we see that this was the voiding pattern. So if we're looking at the average to the max, and we can see it's skewed. Plus, we also have this dribbling happening post-void, which is quite indicative of the physical dynamics of an overactive bladder, where there's this quick contraction, and then there's the dribbling as part of the void. And we can see the time to max is less than 2, but this is actually even delayed because we can see of this child actually interfering or trying to slow down the contractions of the bladder. So in this case, we've got a 10-year-old female, recurrent UTIs, constipation, and damp underwear. Again, the story would be the same. We do our diaries, interview, and Euroflows. So in this case now, so the importance also from the diaries, just to make a point, especially in children, when there is wetting, just also to make sure that it's recorded, are they wet before the void or are they wet after the void? So that's also a very important thing that we don't always think of asking. So they should be checked, especially if they are wearing pads or something like that. And then also for the diaries, if they are wearing things like pads, that those also be recorded and weighed just to assess how wet they are. So in this case, we're seeing a very weird Euroflow, and we can see there's not a bell shape. So remember, bell shape looks like that. And we can see it's almost more of like the staccato pattern. So in this case, there is severe interruption where the child is actually using sphincter to control the void. So quite severe, but in this case, actually still managed to empty the bladder. So this is what we call a dysfunctional voider. And just to look at what a normal void versus dysfunction we'll look at. So key to this is to see what the EMG is doing. So we know that the detrusor has to contract, so we want to see that nice bell shape. But when the child needs to void, so we can see there the sphincter is contracting, then there's that relaxation, and then detrusor contracting, a nice void, a little connect there just to make sure I've emptied my bladder and everything goes back to normal. This is our dysfunctional voider. You can see sphincters closed, child needs to voice, and now we have this activity during the voiding phase and then back to normal afterwards. So normally with these type of voidings, the problem would be that the child is now going to keep residuals, and so the key to that is having these low-grade infections possibly, and over time could scar their kidneys. So renal scarring is quite a big problem in these kids as well, something just to be aware of. So now we would want to do more invasive studies, and these would be just to really see is the bladder safe, and we're now looking at a pressure-volume relationship. So when are these needed? So your big cases are your neurogenics, your uh, um, anatomics, sorry, your valves, maybe extrophy, reflux, and then also for your dysfunctional voiders. So the most important ones are obviously our myelomeningocele, maybe the associated ones, the vactrals, our valves, maybe children in view of transplant, renal scarring, or there's dilatation, maybe to confirm CRC, or maybe in view of surgery. So just to quickly look at how we do a invasive study. So we said it's a pressure volume study. So we're putting in a dual catheter into the bladder. So this is your intravesical. Pressure being recorded, these are attached to pressure transducers. So this is a dual catheter, so we can also fill the bladder. So either would be filled with saline or with contrast if we're doing a video UDS. And then we have a catheter that's in the rectum. So we're saying, basically saying in the bladder, the intravesical is all pressure. So that's inside the bladder or outside the bladder is being recorded there. And with the abdominal or rectal pressure being recorded. This is outside. So if there's a difference between the two, we would do a cough test just to test it. But if there is a difference between these two, then the only thing that can be causing that difference is the detrusor. At the end of the study, then we could also do the Euroflow. And as I said, if we do a saline test, but if we do the contrast, then we've got the added value of seeing the anatomy, which is very, very important. So we'll have a look at the importance of that as well. So very important if we're looking at our detrusor, it is a calculated, so it's PDET is a calculation of PVES minus abdominal pressure. So I thought we can just quickly go into look at different choices. So what is normal and what is abnormal. So we can see here intravesical, pressure being recorded, abdominal, and as we said, PDET is a subtraction. So in this case, there is no EMG, but we can see the filling phase here. So we can see that this is a a study of storage and voiding. So this is a pressure flow study. So essentially, we would look at it as two parts. So during the storage part, what are we expecting the bladder to do? Well, firstly, we need to do that cough test to see that it's working. So we can see there's a slight little um, positive recorded here. So the reason, because we're saying intravesical minus abdominal, so why are we getting a positive? So that means that there is a problem here with the rectal, and the most important reason why we sometimes see these is because of dampening here due to stool in the rectum. So ideally, the child should have a clean rectum at the time of study. Not always possible, and we would obviously see this, and obviously not a beautiful study, but we can see with the cough test everything is working. So if we're looking at compliance of the bladder, so what are we saying compliance is as we are filling the bladder, what are we expecting? We're expecting that pressure to remain low until appropriate capacity is reached for the child. So if there is a very little increase in pressure, then we expect to see a very linear pattern. So we can see from here, this looks normal. And if we record the pressure from here to here, as we would see in the detrusor, we see there's a very little increase. Okay, so rectal is there. Essentially, we can see if there's any activity that's happening in the rectal. So, sorry, if there's any activity happening in the intravesical, is that coming from the rectal or not? So here we can see a very nice normal study. For the, sorry, I was just trying to think. I wanted to mention something else. It's left my mind now. But essentially, as a normal storage phase, and then if we look into where the child's been given permission to void, we can see, so we're expecting a bell-shaped, and we can see here with the rectal cap, it actually was pushed out, but we can see bell-shaped, and then this is what we see in the Euroflow, a nice bell shape. So just from this volume, we can see that the child was full to quite a large volume. So this looks like a child with an adult-sized bladder and everything normal. In this tab, so we've called this a normal overactive. So why is the reason for that? So essentially, when we're looking at again, we want to look at, is there an increase in the pressure during the fill? So if we're looking at the baseline, we can see that, oh yes, I know what I wanted to say. I wanted to say, what was the normal pressures of in the bladder? So normal pressures would be 12 and less. A happy bladder would be pressures of 15. And when we're getting over that, especially when we get to 20, we said this is where it starts to affect the flow rate into the bladder. And when the pressures get greater than 40, that is basically becomes obstructed from a pressure point of view. So if we're looking at the pressures here, we can see that the pressures are actually under, they're around about 12 at capacity. So if we just had to do compliance, that would be a normal compliant bladder. That's why we're saying it is normal bladder. But we are seeing that there are numerous contractions. Okay, so uninhibited contractions. We can see that there is some activity happening in the rectum. They're not always associated with the contractions. So just showing that there is rectal activity here, so not quite a clean rectum, but this child is a child with an overactive bladder. So just another point I wanted to maybe discuss a little bit further, just what I've seen, especially for so children, just even from the flow rate, they get the tower shape pattern, and they get diagnosed with an overactive bladder. And the treatment obviously would be your anticholinergics. They would be put on one, and according to the doctor, would think that the child's been treated. Mom comes and with follow-up visits tells medication is not working, and then they stop. So I just wanted to, it's fine for adults because in adults, we know what our bladder feels like. So if we're having a problem, to take a tablet is fine. But the problem in children is they have never been dry. So they essentially are not in tune um, um, with sorry with sensation to void, especially if there's a problem with this continual contractions. So I can so normally mom would also tell you my child doesn't know when it needs to void or even um, to stool. Um, so and then essentially they stop the medication because they feel it doesn't work. But we have to think of these children. So it's like we can imagine if it's somebody living next to a railway line and you go and visit them and a train comes past and you say, oh my goodness, um, how do you live with this noise? And they'll say, what noise? So the same with these children, with this continuous contraction, the brain actually switches off. So these children um, are, uh, are not aware that they actually need it's not that they can't feel, because if you put them into a situation where where you actually make them aware, yes, um, then they do feel it. So, like if I was doing a study and I say, "Did you feel that contraction?" They would say yes. But if you had to distract them and say to them, "Tell me when you feel a contraction," they'll just say, "No, they didn't feel anything." So it's not that they're not feeling, but there is that's desensitization. So we actually have to almost treat them like a child that you would do as to potty train. So find their bladder capacity and then do drinking appropriately to that, and then put them onto time voids. And then, so if their bladder is small, then the drinking has to be small till the bladder actually enlarges, and that we can increase the times. So they could be on a 2 hourly voiding pattern, and that could go to 2.5 hours to 3 hours. So it's something that you would have to work with over time. But just giving them a tablets doesn't always work. Um, okay, just so in this case, we see now very different patterns that we're seeing as the blood is filling. We can see these increase in pressure. So if we see there's an increase in pressure, we say this is a decrease in compliance. And very important now is we want to know what the pressures are. So unfortunately, when we're doing, unfortunately, because unfortunately, people always look at the values, the results, but not actually at the shape um, of the report, the graph. So in a child where, especially like if we take it, this child, I can see here, so we have filled to 100 moles, but if we're looking at these pressures are very high. So if, for example, the child's capacity was sitting at expected bladder capacity was sitting at maybe at 100 or 150, this would basically be reported as a normal systometric capacity. But the key to this is systometric capacity. So we are filling from the bottom, so we are excluding pressures. So essentially, we actually have to look at where is the bladder safe. So we know the bladder pressures are only safe when they are around about, we say less than 20. So we can see this child is already um, uh, in danger of not filling the bladder from. So functionally, we can say the bladder capacity is sitting closer to maybe 50%. So that would only be a 50% of expected. So um, uh, systometric might be sitting at 100% of expected bladder capacity, but functionally, this child is only sitting at 50%. So this is also where it's very important just to have a look at that. So we can also see in this, so what we also see in that, if we can see, and this is just doing a saline state, we haven't got any there was videos in this case, but if you just had an image like this, we can also see these big drops. So these are also quite important in that they could either be associated with leaking or maybe reflux. So that's also why it's also important to have video studies. Okay, so in this case, we have got a child where again we're seeing there's this increase in the pressure, but now we've got the overactivity. So this is an abnormal bladder, but it has now got detrusor contractions again. So this is what we call a neurogenic. So any bladder where there's decreased compliance, we describe the bladder as a neuropathic or neurogenic. So this is only describing the bladder, not the child. And then this would be a NDO or neurogenic detrusor overactive bladder. So here we have a case of now the very severe contractions happening in our EMG, and we can see, so this was in a very small child, and we can see even prior to the filling lots of contractions, which could also have been, some of them are from the child crying, so we can see that would be from child crying, but we also see there are contractions, which is not coming from the rectal. But quite key to these is these very high pressure contractions in the EMG. So if we're having a child, so this we're saying we can see that the pressure increases. So we know this is a neuropathic bladder. We can see very high pressures, and we can see only leaking at a very high. So very small. I think this was only 15 mils was infused here. So very small bladder with high pressures. These pressures, we can see the baseline is there already over 60, and leak point even greater. They're only leaking at over 80. So very high leak point pressures, high detrusor pressures, and then the added component of the high EMG recordings. So this we describe as a detrusor sphincter dyssynergia. So we would see this, we mainly describe these in our neuropathic bladders. And it's very, very, this is like the severe end of the spectrum. And in this case, with this child, is one of the few kids that actually required an augmentation of the bladder at the age of 4, so very unusual. So looking at our videos, I'm just going to throw some examples here quickly. So I just wanted to show you here. So yeah, we have a child that was sent for UDS. But if we did just a saline line, so if we're looking at this filling line, it actually looks beautiful. And we can see that pediatric capacity was only 14. But having the value of our video, we can see even at this stage it was, I think, 30 mils. We can see basically what we've done is we're filling upper tracts and not bladder. So there's this tiny little bladder, but we're basically filling upper tracts. So this is the problem with doing a saline study when there is upper tract involvement. You would maybe just obviously get a false negative, and you would think everything is good. So if there's any upper tract, it's very important to do a video UDS. So just thought we could also have a look at this. So this is a case of a child that was worked up for renal transplantation. So we can look at the video UDS prior to that. So in this case, the child's expected bladder capacity was 390, systometric capacity was 300, so very good. The CP data was 9 at capacity, And so we're looking at the trace. It all looks very beautiful. And we could see the child voiding phase was done. So we can see here's the voiding. We can see a little bit of the valve there, and basically incomplete bladder emptying. But this child was then managed on CRC prior to transplant. Then post-transplant, the child was having recurrent UTIs, and we were asked to repeat the UDS. And we can see now from how this whole bladder has actually changed. So expected bladder for this child is 400 to 600, is obviously added. Adult, now we see the capacity is only sitting at 250, it's actually come down a little bit, doesn't look that much smaller. P-DETS has remained the same, but what have we seen here? These numerous contractions. And with these contractions, we can see even there was reflux at 50 mol. So now this bladder actually has changed post-transplant. And so here we can see this reflux into the graft, and even post-CRC that there's still some contrast remaining there. So just making this child obviously for risk for that transplanted kidney. Sorry. Oops. Just got this. Can't see the top of my screen. So I thought we could do is just to look at a couple of traces and just to follow some kids. So just wanted to show a couple of cases that we have worked through. Are we all still good? Any questions? Sorry, maybe.
Everything's good so far.
Okay, thank you. Okay, so in this case, if we look at the study, we can see lots of rectal activity. So the other thing just to point, so obviously if I'm working with a smaller child, it's obviously difficult to ask them to cough. And what we do then is we just kind of press on the bladder just to see that we are seeing. So there would be like a little bit of a pressure test done there just to see that the study is working. And then we're seeing in, as the bladder is filling, we're seeing these contractions. So essentially we're sitting with the child with a, I think it was a myelomeningocele with a neurogenic bladder, small bladder capacity. I think this was only 1% of expected bladder capacity. Oh, sorry, I'm looking at the wrong child. This was a little bit older one. Okay, let me just follow through. So, but essentially what would happen is the child would go on to treatment and start on CRC and anticholinergics. Oh yes, I remember now. So this was a child, so the child was started on anticholinergics, and we can see this was, sorry, just to go back. So this was at age 5. So the child was obviously still wet, and this is came in to have the study done. So this was a follow-up at age of 8. And the child now presented, he was wet all the time. And we then discovered essentially mom didn't think that the medicine was anticholinergics was working. So essentially was not giving the medication. And we can see how this bladder is actually now decreased in size. Oops, where's the... Oops, sorry, they're a little bit out of sync. So I wanted to share this one. So that is the UDS study that saw, and if we're looking at the shape of the bladder, so we can see that it's starting to having almost like a little bit of a spinning top kind of picture at the bottom. So we can see that's why, and we can see with these contractions that the child is leaking. So, so because of that, the size of the bladder has decreased because the child is basically wet all the time. And yeah, so then again to reinforce the taking anticholinergics. So this is just going back to this study. So if we're looking at this one now, so essentially we would think now that everything looks a bit better. We can still obviously see all these contractions, they're numerous right from the beginning. And if we just did a saline sound, we actually fall to 200. So we would basically think that mom is giving medication and yes, everything's not under control, but it doesn't look too bad. But when we look at the study, sorry, they just got separated. So this is this child's graft, and we can see now we weren't filling the bladder because the child is just refluxing, and so we can see that was at 51 moles, at 90 moles. So it's just refluxing and then refluxing starting into the other kidney, the left one, and we can see how severe the reflux is, and this is at 200. So essentially, this bladder is not a safe bladder, obviously, and quite severe damage being done. So just to look. So in this case, if we look at that, it looks so much better than that, and yet this is only because it's all the damage now, so we're filling up the tracks. So just something to be aware of. Then the importance of actually doing looking at the shape of the bladder and what's going on. In this case, what I wanted us to show is if we're looking at this child now, we're seeing that the compliance looks very good. Obviously, there's lots of rectal activity, so this is why this line is not a beautiful line to look at, but essentially it looks like from a good fill. So from the storage phase, everything looks good. So what I wanted to show us, so if we're looking at the pictures, so if we just had that part of the study, we would think everything looks good. But here we can see on the full that there's actually already early on, there's reflux bilaterally. We can start seeing the damage on one side of the kidney, and we actually see reflux into the right and reflux into the right there. So this all would still be looked, okay, there's minimal reflux and we wouldn't be too concerned about it, but also just having the fact is, I think with this child, there was having recurrent UTIs and some dilatation of the upper tracts. So if we looked at the voiding, so in the next one, we can just look at the voiding. So now we can see the child is voiding, and we can see with the voiding that reflux. And the child actually empties the bladder, but everything is sitting up into the upper tracts, and then there was poor drainage of the upper tract. So these are also just very valuable. So in this case, we can see the flow rate did not look too bad, but obviously there was a decrease in the volume, and then there would be some secondary fall post. But just the value of having the videos to actually have a look at these things and see what's happening. So in case number 3, so this is a 13-year-old male. So expected bladder capacity, because we're using weight, is sitting at 70. So this was a child with a myelomeningocele already, and on ultrasound showed hydronephrosis, and MCG that was done showed a small bladder but no reflux. So just the point of is often that I've seen when people look at a tracing like this, they say, oh, it all looks normal. It's flat and that's just a void. But we must understand that these are small trials. So it's very important to look at the volume. So in this case, it was sitting at like 29%. So this was, I think it was um, um, 20 mils or something. Um, yeah, round about there. So basically, it's just a small bladder and there's just contractions and the child is emptying. So then CRC and um, oxybutynin was started. So just on that fact. So I just also want to make important thing. So we see sometimes what happens is the children are started on anticholinergics because that's decided that's what they need, but CRC is not always established. So, and we have seen it. So, if you're getting the anticholinergic and it is a child with a high lead point pressure, so yes, you bringing that down, but and maybe creating a bigger bladder or a safer bladder. But essentially, it's not safer because the child's not emptying. So it's very important that CRC needs to be established before you actually start your anticholinergic. So it could be, obviously, if it's a child that's coping, it could be one day, it could be a week. But you need to establish that, especially in the littles, because sometimes parents have a hard time to just understand that they actually need to do it. So carrying on with this child, so we can see the child, this is now at 2, so this was like 7 months later, where we're just checking, and we can see that it looks better. We can still see contractions, and we see we have actually now managed to um, double um, the capacity of the bladder is sitting at 60, so not ideal. But the fact is that there was underlying hydronephrosis, but we did not do a video UDS because on the MCT it said there was no reflux, so it was not decided it was not needed. Essentially, the child was then only followed up at age 6. But now, quite sadly, here, the most important thing that's for some or other has not been saved, sorry, I checked this morning, um, is the video images of this. But I just wanted to show you because I think this is such an important case. So we see this is now at age 6. This child is a myelomeningocele in a wheelchair, so obviously at risk. Children in wheelchairs are at risk. And on the referral was on the KUB was mild dilatation, and they were not too concerned with this. Um, when I asked the dad what he was removing, he said that the child's voids well and it's almost empty, and they take out sometimes 60. So, and if we're looking at um, the shape, we can see there a small bladder, but the pressures don't look too bad. But unfortunately, like I said, I haven't got the videos. But essentially, what it was doing, there was no bladder, and we were just filling the left kidney, and we had this huge dilated kidney. I'm just going to go to the next one because, yeah, just a little bit does a summary. So essentially, after that, the child had a MAG3 and kidney was found to be non-functioning. So therefore had nephrectomy, so they could use that. And then they enlarged the bladder to do uterocystoplasty. Then the child came back. Now it was 2 years later because now the child is sitting there with the right kidney, which was doing fine, now is not growing. And so essentially, they enlarged the bladder, but now we're sitting with a child. So if we're looking at the pressures, we can see they are still very, very high. Obviously, there's also a problem with um, the rectum not being cleared. But if we're looking at the stress, so from a functional point of view, the bladder's only sitting is about safe at about 50%. So although this bladder has, from a systometric volume, is a lot larger, but from a functional point of view, a lot smaller. So the other added problem to this is, which also discovered, is because the child was not really compliant with CRC um, uh, most of his life, because not needing it, because the bladder was always empty, but this was just due to this child having this tiny little bladder. So the parents and the child didn't really understand the need of doing regular CRC. And yeah, so the importance of making sure that they get re-educated, the importance of doing that CRC regular, and also because of these high pressures is then adding overnight drainage. And I'll just show pictures of the benefit of that a little bit later. So just because we've done the augment, that not everything is good, because now we're actually starting to damage the good kidney. So yeah, so there's good and bad about of taking away that non-functioning kidney. Okay, so in this case, we've got a child, a 7-year-old female. Yeah, so she had feet amputated. KUB was essentially normal except a small bladder, but this child had defaulted a few times. And so this was her baseline study. So we can see a small bladder, high pressures, and again, from a functional point of view, would be less than what we're seeing here. So quite concerned about her. So she was followed up. So this was a year later, just to see how she was doing. And so she started on the titrapan, and we can see now from, oopsie, sorry, gone the wrong way. Yeah, so from the very small bladder, you can see there 40 mils, to actually managing it. So quite a good response to medication, but we still see a very high pressures. And if we're looking at our images, so we can see the shape's not too bad, but we can see there is reflux. So she was booked to come back for deflux and for Botox, just to improve the pressures. And then this child defaulted and struggled to get hold of her for, I think it was 2 years. Eventually, we got her back just to have a look at the study. So in this time that she had defaulted, she'd actually stopped all her medication again and was now non-compliant with medical therapy or CRC. And if we look at the study, so now we have a tiny little bladder. We actually only, she started already with these high pressures after only 11 mils. So this bladder is almost non-existent. And you can see it's supposed to be sitting at 330. And if we're looking at the images, we can see how she's damaged her bladder. So just the importance of actually having a video UDS, and you can actually see how this has changed. Okay, this is a next case. This is a 6-year-old male. So this child had been seen at Red Cross from the age of about 2. He was also a myelomeningocele. He'd already had a sting and interventions, but was not on CRC and medication, which was started. And So he had good response to his expected bladder capacity. So that always improved, but we could not improve on the pressures. And so over the years, the pressures always remained high. So we always had high pressures and numerous Botox injections and recurrent UTIs. So it was then decided to just do the baseline again and see is the Botox working or not. And we can see this was the study prior to that. So we can see these high pressure contractions. Lead point pressure was high and essentially not a happy looking bladder. And if we're looking at the shape, we can see this very trabeculated, like fir tree and a reflux. Post Botox, so we can see the Botox. So essentially, with the Botox, didn't change the pressures, didn't change the shape. The only thing is the overactivity calmed down, but we still ended up with a high pressure bladder. So at this stage, the child would normally be offered augmentation, but because of the social circumstances, this was not uh, offered. And um, then we discussed the option of doing Botox and overnight. Because if you're thinking of during the day, you are decompressing that bladder by doing the CRC, but overnight there's nothing. So if this is a high pressure bladder, it's sitting like that the whole night. So it was started Botox with overnight drainage, and then we reviewed after um, 2 years. So this child was now 9 years old, and we can see um, a big change in that the tracing. So now um, expected bladder capacity is not too bad, but we still had some very high lead point pressures, but much better. So if we're looking at the shape, did we change that? And we can see actually the whole bladder has calmed down, and we also sorted out the reflux and the UTI. So that was good improvement. And then we continued for another 2 years and reassessed. And we can see the child now at age 11. And we can see beautiful bladder, good pressures, good shape, no reflux, and doing really, really well. So just the benefit of doing the overnight with the Botox, um, and obviously he's intermittent CRC and oxybutynin during the daytime as well. Just this case, so I just wanted to also just to share the importance of sometimes just looking at the results and not thinking that there will be damage. So very importantly, if we're looking at especially for our neuropathic children, so because of the micturition reflex, also a lot of times um, the bladder emptying and all that looks good. And then the child only gets into trouble. Sorry, I didn't show an example of this, but so essentially the bladder, when you're doing the UDSs, all look fine when they're less than 3, and the damage only starts, you only start seeing the damage at age 6, 7, and normally that is when they come back when they are now needing to go to school and they're still in nappies, and then we actually see the damage. So it's very important with your neuropathic bladders that if anything, if it looks all good in first year of life, still to make sure that mom understands the child needs to be followed up on a yearly basis and that it needs its kidneys checks and needs a KUB a regular basis, and that we need to reassess the bladder, especially when at the age of potty training. So it's very important that we do a video UDS. We do it in the first year of life. If you miss the beginning, that's fine, but then it should be done closer to 1 year. If you do it too quick, it's going to look, everything's going to look good. And then you might not, then this child might go, might be kind of said that it's a safe bladder, and then by the time that we pick up, it's too late. So if you are going to do the UDS and you haven't done it, or essentially rather start treating and then do the first video UDS at um, by one, age one. Obviously, if there is a concern, obviously if there's upper tract involvement or anything, you would going to do it earlier. I'm just saying, if everything looks normal and you're not concerned about it, you should do it by age one, and then it should be done again at between age 3 and 4, when a maturation reflex has now disappeared. So now that's when the bladder starts going off. Um, and if everything is normal, then you can just do it at age 9. Otherwise, obviously, if there's problems, we would do more intermittent. So I just wanted to show, so this child was almost 2 here and essentially didn't look too bad. This child was just a child that was crying, but I could see here from, if we're looking at the shape of the bladder, we can see it's actually starting here at the top. We can start seeing that um, there's pressure in it because it's creating almost this like damage to the top, which if you're looking at the pressures, you can't really see, and you would say everything is normal. So anyway, this child was started on CRC and Ditropan, and then if we follow up, so we can see here now where we would follow them up at age 3, and if we're looking at the video UDS or at the tracing, pressures don't look too bad, and if we're looking at our images, we can now see how that damage is only more visible, but yet it doesn't look like it's a bladder under pressure. So as this bladder is changing shapes, it's allowing this fall. So we can see the bladder capacity here was, so the 2 previous studies, the previous one and this one, our expected bladder capacity was normal. So yeah, but then just the child was then now brought back at the age of 6. And here we can see that the pressures have now gone off, and also that the bladder capacity has decreased. So, so now we are seeing the changes at a very delayed time. So the damage, and because of this shape now reaching its capacity, now the pressures are increasing and the capacity has decreased. Okay, thank you. I hope that was helpful.
Thank you so
Any
much, Jeanette.
questions?
Sure, I want to just check if there are any questions on the floor, any questions in the chat? Anything from our side? Jeanette, we just want to thank you for your presentation this morning, and sharing your expertise and your time with us. We really appreciate the talk. Thank you so much, everyone, for joining. We will see you all next week for the next webinar. Thank you so much.